Lecture 6 in this respiratory package is proning and positioning. The name of this talk is to help you to understand the basic principles of placing patients in the prone position and avoiding proning-related complications, and the essential nursing care of patients who are proned. Dr. David McWilliams is going to undertake this talk, and he is a consultant physiotherapist in intensive care at the University Hospitals Birmingham. David is internationally recognised as an expert in critical care rehabilitation. So thank you, David.
Thank you, Una, and it's a pleasure to be delivering this talk as part of the SPACE programme. So the real objectives today are to help people to understand the basic principles of prone positioning, to discuss the procedure, or certainly one way in which proning can be performed, some of the common complications that may arise, and then how to care for the patient who's in the prone position. Now, just to really set the scene, I think it's important to understand the rationale behind why we would place somebody into the prone position. So I'm going to start by having a quick look at VQ, or ventilation and perfusion, and the specific impact of ARDS, or acute respiratory distress syndrome, on gas exchange, and why a certain group of patients need more support with their oxygenation and gas exchange by being placed into prone. And then, as I said, some of the complications and precautions. So if we start with some simple definitions of ventilation and perfusion. So ventilation relates to the supply of oxygen through the lungs and actually taking oxygen in with the breath and then that gas exchange across to meet the perfusion, which is the supply of blood. And you get a ventilation perfusion mismatch when for some reason the normal balance between that oxygen entering into the lung and the blood supply going past being disturbed. So in terms of ventilation, just to get our head around this first, ventilation will increase down the lung from the non-dependent apical to the dependent basal regions. I'm going to focus in on this in a second. You get more ventilation occurring in your right lung due to its larger size, being that the heart sits on the left-hand side of the chest. And in the supine position, for somebody who's spontaneously breathing, the diaphragm is pushed upwards by the abdominal contents, and that will increase its efficiency. It's put on a little bit of a stretch, which means it can work better when you're breathing spontaneously. But if we just focus on that concept of ventilation increasing down the lung, we're going to start by thinking of a slinky toy. So this is one of those things that's a spring that will basically walk down the stairs. But what happens is if you hold a slinky in this way from the top, it would stretch itself out, so it's quite expanded at the top there, and is all squashed down at the bottom, because at the top you've got the most effective gravity, whereas at the bottom, when there's less weight, it's all bunched together. And this is basically what happens within the chest wall. So if somebody's either upright in a standing position or a sitting position, the weight of the whole lung is acting on the top component, and that's actually stretching over these alveoli and stretching over those top sections of the lung, whereas at the bottom, the lungs are a little bit all squashed together. And what this means is when somebody takes a spontaneous breath, so when you breathe for yourself, your diaphragm will move down, your intercostal muscles will move out, creating a negative pressure, and that will suck air into the lungs. Now at the top, where you've got these airways that are already open, there's very little room for maneuver for extra air to be inhaled in. Whereas the airways at the bottom that are a little bit squashed down have the greatest potential for change and therefore suck in the most air. So in an upright position, it's these squashed together regions of the lung that actually facilitate the best air entry for gas exchange. And this is matched really nicely by perfusion. So your pulmonary vascular resistance is very low. So blood that's coming out of the right side of the heart has to just go through the lungs before going back to the left side. So it's under much lower pressure than the blood coming out of the left, which has to go around the entire body. And the pulmonary circulation itself has a vast array of pulmonary capillaries. So it's shown quite nicely in this picture here. You can see that those blood vessels are almost entirely coating the outside of the alveoli and the outside of the lungs, making it a really efficient surface for gas exchange to occur. But blood itself is a fluid, so it's very affected by gravity as well. So if we look at these VQ scans, what you actually find is in the blood flow, gravity is going to have an impact. So if the person's upright, you're going to get more blood going down to the base than you are to the apices. If somebody's lying on their back, more blood is going to go to the back than goes to the front of the chest. If you think of a child standing on their head, for example, blood rushes into the head because it's going to be affected by gravity. Blood will predominantly be directed downwards. And what this means, well, actually, when it comes to gas exchange in somebody who's breathing normally for themselves, well, you need air and blood to be in the same place for gas exchange to occur. And in somebody breathing normally, as we've seen, both ventilation and perfusion increase the further down into the lungs you go. So both are more prevalent at the bottom of the lungs than they are at the top. And because it's very much affected by gravity, it doesn't matter what position we get our bodies into, the lung will be squashed down with the greatest potential to change, and the blood will run to the bottom because of gravity. So no matter how we turn, the two things are in the same place at the same time. And that's why the human body is such a wonderful thing, that it always optimizes this gas exchange when we're breathing for ourselves. Now, the problem comes when we add in a ventilator, because that changes the entire nature of how we're breathing. So when we breathe spontaneously, as I mentioned before, the diaphragm will move down, the ribs will move out, guided by the intercostal muscles, creating a negative pressure or a vacuum, which will suck air into the airway and into the lungs. When we take over somebody's breathing and we put them onto a ventilator, we change this process round and we actually blow air into the airway and down into the lungs under positive pressure. So when we consider those airways before, you remember we said the airways that are at the bottom that are squashed down have the greatest potential to change, whereas the ones at the top are actually, there's very minimal gas exchange that can occur. Well, if we think of the airways like balloons, we've got two scenarios here. We've got a balloon that's already half inflated and we've got one that's completely flat. Well, we know when we're blowing a balloon up, actually, once it's halfway open, it gets much easier to inflate than ones that's completely flat at the start. So what happens when we start putting this positive pressure in from a ventilator is that ventilation is directed down the path of least resistance to start to increasingly inflate those airways that are already open and away from those airways that are collapsed and giving quite a lot of resistance to that airflow. So what actually happens when somebody goes into a ventilator is the air is directed upwards, causing, if anything, huge inflation or over distension at the top and very little or minimal change in the bottom. Whilst the ventilation is changed, the blood continues to be acted on by the force of gravity. So ventilation is now diverted to these non-dependent upper regions and blood is still being diverted down. With the addition actually of, because we're putting positive pressure now into the top of somebody's chest, that will also cause a resistance to blood flow, which if anything will divert more blood away from those aerated expanding areas down to the base of the lungs. So just by placing even a healthy lung onto a ventilator, we create a VQ mismatch. Ventilation goes to those already open areas at the top, and perfusion is directed according to gravity down to those areas at the bottom. So we start to get a problem and we start to get a mismatch in ventilation and perfusion. And what that's going to do is prevent the oxygen that's being breathed into the lungs, either or driven by the ventilator, getting into the bloodstream and oxygenating that person, or even the removal of CO2 in the other direction. Now, when we then add in the most severe cases of COVID or people that develop acute respiratory distress syndrome, that's going to have even more complications. So we're going to start with the left-hand side of this picture. And what we can see is normal lung anatomy. And again, it's a highly efficient system. So we've got the alveoli here, which is the most distal unit of the lung, which is involved in gas exchange, which is one cell thick. So that's one single cell. We then have a very small fluid-filled interstitial space, and then the one cell single walled capillary. So your oxygen molecule will come in. It has to go across one cell, a very small fluid space, another cell, and it's in the blood with a red cell waiting to pick it up with CO2 going in the opposite direction. So a really efficient membrane for gas exchange. With ARDS, what we know is there's an inflammatory process which is triggered. So if you think of, if you stub a toe, if you twist your ankle, you get an inflammatory response in that area. So you get protein-rich fluid rushing into your ankle, it causes swelling. You get heat as the extra blood flow comes in to try and repair any damage. You get clotting factors in case there's a cut. Now, what happens with acute respiratory distress syndrome, the ARDS, is something triggers this exact inflammatory response within the lungs. So again, you get an influx of protein-rich fluid, which now fills the alveoli. You get your immune system starting to attack anything that's in sight, basically, and starts to damage that really thin alveolar wall. The fluid, as well as going into the alveoli, is now going into the space between the alveoli and the capillary. And you can even get capillary damage as these clotting factors come in and the immune system is starting to attack what it thinks is a foreign attack. So now your single molecule of oxygen is coming in, and rather than this very short trip or hop, skip, and a jump into the bloodstream, now has to swim through quite a lot of fluid, through a damaged alveolar wall, through this interstitial fluid, and that's if there's even a blood vessel available or a red blood cell ready and waiting to take the oxygen. So it really causes this disordered gas exchange. Now, what makes ARDS even more complicated is it's not a homogeneous process, so it doesn't affect the entire lung in the same way. And the best way to think about ARDS is a wet sponge. So we'll use the wet sponge analogy. So if we consider this sponge here has been dipped in a bucket and it's been picked up from the top, what you get at the bottom is this fully saturated of water. All the water runs with gravity and fully saturates the bottom of the sponge. In the middle, you get a bit of a combination. So there's still some water, but there's also some air. And then at the top, you've got no water because it's all run down, and normal air-filled sponge. And this is what happens within the lungs. You get areas at the bottom which are completely fully saturated with this inflammatory exudate. It's non-recruitable, it's damaged, saturated lung. In the middle, you get lung tissue which has some fluid but some air and could be potentially recruitable and could be ventilated. And at the top, you have relatively normal lung tissue that's been unaffected, which we sometimes term the baby lung because it's a normal lung but much, much smaller. And to keep this quite simple, the idea then becomes, or why this gets so difficult, is when we come to ventilate people, we're actually trying to ventilate, if anything, 3 different lungs within the same chest. So this gets quite complex. You've already seen from the last picture of the ARDS the difficulties with getting oxygen into the bloodstream. And in the most severe cases, this can cause quite critical levels of hypoxia or demand quite high pressures on mechanical ventilation, which, as I'm sure you've heard from previous talks, can be damaging to the lung itself. This is a CT scan of a normal chest. So this is somebody that's lying on their back. You're standing at their feet. So this is the right lung. This is the left. What you see here is a really nice mixture. The blackened areas being air, the white areas being blood vessels, with a really good, efficient area for gas exchange. With ARDS, this is a similar scan taken in the same way. So you've got the right-hand side here, the left-hand side. And what you have is this completely damaged, saturated with fluid area of an ARDS chest. The mid region, as I mentioned, with some areas that are damaged and fluid filled, but some areas and some pockets of air, and then more normal lung tissue at the top. And you can see the challenges of then trying to ventilate this person. So significant lung damage, which is causing quite significant implications for gas exchange. So this is where proning comes in, and this is the rationale really of how we can try and improve people's oxygenation in a damaged chest requiring quite high pressures for ventilation. So the indications, it's for those patients really recommended where they have severe ARDS. So these are the ones with really poor gas exchange. They're not getting enough oxygen on board. They're not able to get rid of their carbon dioxide despite quite high levels of pressure on the ventilator, maybe moving up towards the highest pressures that we'd really want to give. That's measured with something called your PF ratio. And this is really looking at the amount of oxygen that's in somebody's blood based on the amount of oxygen that we're having to give them from the ventilator. And anything less than 150 would start to suggest they're moving into a more severe phase of gas exchange limitation and they might need some more support. People that are on quite high levels of oxygen, so those are requiring over 60%, so 3 times what we'd normally be receiving, and those high ventilatory pressures, so high peak to hold the airways open, and then high pressures on top to try and deliver any sort of tidal volume. So we're going into the realms where to get the oxygen on board, we're actually at quite high risk of causing some lung damage. So prone positioning, why is it so effective? Well, there's a couple of key concepts really. So first of all, we have a larger surface area at the back of our chest. So when you look at the lungs anatomically, they're actually bigger at the back than they are at the front. So we start to utilize that extra surface area. We also have an increased blood supply to the posterior aspect of our chest as well. So you start to use more surface area and more blood flow into those 2 areas. The heart itself as well, you can see on this picture, is a very large organ sitting on that chest wall. And the heart actually rests on the left-hand base in a supine position, and that can start to cause some compression atelectasis and collapse, and also restrict air entry. When you flip somebody onto their front, what you see in this picture here, you start to utilize that bigger surface area at the back of the lungs, that better blood supply. As we showed with the slinky, the weight of the lung will start to stretch open these areas that have previously been collapsed and start to allow us to utilize areas of the lung we've not been able to before. But the heart also is taken out of the equation because it sits quite nicely on the sternum. That releases the left base to start to expand in a much better position, and it takes some of the pressure off from the breathing within the lungs. Proning is also quite a useful position to help to drain any excess secretions which may have built up, and certainly in quite a number of COVID patients we've seen in Birmingham, secretions has very much been an issue when it comes to ventilating these patients. Ideally, the recommendations are if we're going to prone people, we should do it early. And this is before the real onset of lung damage, either due to the disease process itself or the high ventilatory pressures that are required. So the decision to prone will be made by the intensivists, hopefully or usually within 48 hours of the onset of mechanical ventilation. And it should be used in combination with lung protective ventilation. So what we're saying here is to get gas exchange with these people's chests. Normally you need to use very high pressures to hold the lungs open. But when you're using high levels of PEEP to hold the lungs themselves open, it doesn't take much more pressure to go into dangerously high levels of pressure for lung expansion. So the technique we tend to use is a high PEEP to hold things, but then low tidal volumes to make sure we're not damaging the chest. So using these two things together has been shown to improve outcomes. It's also recommended that when we place people in prone, that's usually for a minimum of 16 hours each period, allowing the lung time to recruit, open up those collapsed down areas, allow gas exchange to be re-established, and hopefully then retain that when people are turned back into a supine position. But often it requires quite deep sedation and possibly even a paralyzing agent. It can be quite an uncomfortable position, as you can imagine. We're taking over somebody's breathing, relying them on their front. Sometimes we'll need to actually keep them very deeply sedated to be able to deliver the ventilation that we want to deliver and maintain this position safely. So in terms of the procedure, the best thing to say is actually the hospital that you work at will, I'm sure, have their own procedure and their own policy, and it's important to get familiar with what this is and how this is done. I'm going to describe one of the methods that's widely used in the UK, and this is based on recommendations from the Faculty of Intensive Care Medicine in the Intensive Care Society in the UK. And this is one method, but it might be an adaptation of this or a variety of this method or something different. But just make sure you're aware of what's done in your own trust. And also what we tended to find during the pandemic was that very often we had the creation of proning teams, and there may even be specific teams that come on and see through this procedure. But you need an adequate number of staff, and that's usually between 5 and 7 people. So you'll have one person at the head end managing the airway, managing the head, and then either 2 or 3 on each side. In preparation, things that you can do to get ready for this change in position and prepare the area, or make sure the airway is secure and that the difficult airway trolley is available. So if there are any mishaps, if the tube becomes displaced, for example, everything's ready, everything's on standby if that needs to be replaced quickly in an emergency. And that we're checking things like whether it's ties, that the ET tube itself is tied in, or whether it's taped to the cheeks, just making sure that everything is secure. Pre-oxygenate the patient, and usually the patients will be put on 100% oxygen for at least a few minutes before the maneuver to make sure they've got as much oxygen on board as possible. Ensure that all the lines are secured, visible, and have enough length. And I think you can't spend too much time on this part. Actually, planning the area is the most important concept before anything else takes place. Make sure you're aware of every IV, every line, every catheter that is going in. Make sure you've got enough length. You can see them throughout, and you know how they're going to move. So almost work through that in your head as the patient is turned over, where the lines will go. Stop the NG feed and aspirate as well. So just to make sure that the patient isn't going to vomit, there's not going to be any risk of aspiration of that into the airway, or that you've turned somebody over and they vomit and then they're lying in that vomit itself. So just to try and keep the airway as clean as possible, but also empty in the stomach. The procedure I'm going to talk about is called patient wrapping, and there's some pictures here to kind of try and explain in better detail what I'm talking about. So the first one is, and these are used in some units, not used in others. We certainly do in ours, and you place pillows over the chest, the pelvis, and the knees, and then the patient is covered with a clean sheet on top. Okay, the head and neck remain exposed again, so you can see the patient, you can see the airway, and you know things are being done safely. And this is why it gets important to really check those lines and know where things are before, because at this point we're starting to now cover the patient over. There's a slide sheet underneath, and then what you see is the top sheet we've now placed on and the bottom sheet, and then rolled together to almost have this wrapped up. I think you could think of it like a sweet or something else, but they're wrapped up from each side. So the patient's very much cocooned now between the two sheets. What then happens is on top of the slide sheet, the patient is rolled or they're slid horizontally to one edge of the bed, and then they're rolled towards the direction that they're going to be turned. This is very much led by the person at the head end of the bed with the airway. They should be the person in control, calling out the commands and making sure every member of the team knows what they're doing, what their role is, and in a coordinated step that everybody's doing things in the same time. As the person's rolled onto their side, the people on the left-hand side of this picture who the patient's going to be rolled towards then switch their hands from the bottom to the top, and then as a group they gently lower the patient down so they're lying on their front. Now, there's some important checks to do immediately once the patient has landed on their front. As such, the first one is to make sure that the endotracheal tube hasn't been kinked and to make sure that that airway is still patent. And hopefully the person at the airway end would be monitoring this throughout anyway. But also making sure that the CO2 monitoring trace is still present. One of the risks of turning somebody from their back to their front is, as we've said before, dislodging that ET tube. So by having CO2 monitoring in place, this will let you know that the ET tube is still in the right place, the patient's still ventilating, and therefore expelling CO2. You can now start to reattach your monitoring, so reattach your ECG electrodes on the patient's back and start to reconnect and resume any IV infusions that you were disconnected before for the safety of the turn. But just making sure that the patient isn't lying on any of these lines, attachments, or monitoring pieces of equipment, thinking pressure all the time, really. The potential complications, well, probably the most cited injury for people who are placed in the prone position is pressure sores, and we'll talk about that in a little bit more detail in a second. ET tubes blockage, and that could be due to kinking as we turn the head and turn them over, or excess secretions. Quite a common occurrence at times as people move is you dislodge a lump of sputum, and that can start to impact on gas exchange and oxygenation. Again, we'll talk about that more in a second. You're at risk of facial or periorbital edema. As you'd imagine, with that kind of change in position from front to back, it's quite a high risk of disconnecting IV lines, ET tube displacements, or even kinking lines. If somebody's got an IV infusion, maybe they're on hemofiltration to support the kidneys. If we don't do this properly, you could start to kink a line, and that's going to impact on the delivery of either the medications or the removal of blood for CVVH. Potential for cardiovascular instability. These patients are very, very sick. They're generally prone because they're reaching quite a critical point with their oxygenation, so there is a risk that they could be unstable during this maneuver. A brachial plexus injury. So often, as I said before, these people will be deeply sedated or paralyzed. We're flipping them onto their front, and that can put, without adequate support, quite a lot of pressure through their shoulder joint. The shoulder itself is quite a unsupported joint that's very dependent on the muscles around it to keep it in place and to protect it, and inappropriate positioning of the upper limb can actually put quite a big stretch across the front of the patient's chest, and that's puts you at high risk of a brachial plexus injury. And also, if not done in a coordinated manner, there's quite a high risk of staph injury as well. So this is why you should have very robust protocols and somebody clearly dictating what's happening and when, and making sure that everybody understands their roles. So in terms of pressure, in our trust, we adopt the swimmer's position. This is quite a common one used, and this involves having one of the arms up in the elevated picture, like in the picture, with the head turned towards that arm. You can also see just about there's a pillow underneath to protect that shoulder joint a little bit. And if you do use this position, what tends to happen is you switch the arms every 2 to 4 hours and turn the patient's head in that direction. It allows some protection of those joints. I know in some units they might have both arms that are elevated, some would leave both arms down. But again, this is why it's so important to look at your specific hospital and your specific hospital's policy. The pillows, if they are used, reduce the pressure on the chest, the abdomen, and the knees. For example, taking away the harder surface of the bed allows the lungs to expand a little bit better. It prevents overstretching of the hips and the hip flexors, or any damage to the knees, overstretching of the ankles, for example. And we position the bed into a 30-degree reverse Trendelenburg position. So the whole bed will be tilted so the patient's head is up to try and help with prevention of pressure going into the face and any regurgitation that could put the patient at risk. In terms of chest care, as I said, often these patients are deeply sedated and paralyzed. What that then comes with is a lack of any cough effort. So if there are any secretions present, often the patient aren't able to clear them themselves. there's a risk of secretion retention or blocked ET tubes. So it's important that you perform suction at least once per shift, even just to make sure that that airway is patent. But if you do find the secretions are very thick, very tenacious, very difficult to clear, chest physiotherapy is often indicated. There should hopefully be physiotherapists on the unit that can come and help, or senior nursing colleagues that can also help you with this kind of incident. One of the big risk factors for a patient in the prone position is damage to the face and the eyes, and that's either from direct pressure of lying on their front or the raised pressure due to gravity and edema. One of the reasons we position the whole bed into 30 degrees is if a patient's flat, a lot of that fluid will rush into their face, can cause quite significant facial swelling and damage. So if you position the bed at an angle, this will move the fluid further down into the body, into the abdomen, the legs, for example. But when they're on the front, it's important that you check the ET tube, make sure it's not putting any pressure unduly on the patient's cheek, inside the mouth, and look at the ties for any signs of pressure. Check the NG tube and check for pressure inside the nose, as well as if it's going across the face, to make sure the patient isn't lying on top of it, and if they are, whether there's some sort of pad or dressing that can be placed between them and the bed to relieve some of that pressure. Regular skin assessment is important. As I said, they're going to stay in this position for 16 hours. It takes us away from the 2 to 4 hourly turns, whatever we'd normally be doing for pressure care. So we just need to make sure that we're keeping an eye on the skin and what's happening there. From an eye perspective, it's usually recommended to apply some eye ointment, cover the eyes then with eye pads and secure with tape. And that prevents any corneal abrasions, so to stop the eyes rubbing or being damaged by being in contact with the bed or the sheets. And also just to ensure the ears aren't bent over. It sounds like a small thing, but if somebody's lying on their front with the ear trapped underneath for quite a few hours, it's going to be very uncomfortable or could potentially cause quite a lot of damage. So in conclusion, the prone position is widely used, and we've certainly seen it used in, I think it was around 70% of our patients with COVID in Birmingham were placed in the prone position at least once. When utilised, because of that bigger posterior surface area of the lung and better blood supply, it can result in quite significant improvements in gas exchange very, very quickly, and therefore oxygenation. It requires a skilled team and excellent communication, and I can't overstate the importance of having good teamwork and communication throughout this process. Complications can be common, but they can be prevented with care and attention to detail. And quite often something like checklists are useful to support this process. And you can have that person at the end of the bed, at the head end, for example, working through that checklist, making sure everybody knows their role, everybody knows the processes that you're going to go through, and making sure there are certain checks performed for safety before, during, and after the maneuver. Thank you very much.
Thank you, David. That was excellent, and really, really informative. I imagine for staff coming to work in ICU to see patients nursed in a prone position is a very foreign thing to them, and they probably have lots of questions, which I think your talk will have answered quite a lot of them. For me, one of the things I was going to ask, and you touched on it a little bit there, we've heard throughout the lectures in this respiratory series about the importance of nursing patients in a 30 to 40 degree head up tilt when they are nursed in a supine position. And how's that managed best then, or achieved at all, when a person's in a prone position?
Yeah, so I think this is the slight difference when somebody's in prone, because normally, obviously, we'd use the sit function on the bed to lift their trunk so they're in an upright position. We can't do that when somebody's lying on their front. It would be extremely uncomfortable if we tried. What we do is we keep the whole bed flat, but then we tilt the entire bed up to 30 degrees if we can achieve it. And that will have a number of benefits, from a kind of preventing regurgitation and possible aspiration of any gastric contents, which have been shown to increase the risk of pneumonia. It will help, as I said, to try and reduce pressure, particularly on the face, the eyes, which can cause quite severe and significant injury, but managed within the safety of that patient's position. So it's about tilting that whole bed rather than sitting them up as we normally would, but it can certainly still be achieved.
Yeah. And that's great, and it's brilliant, the innovative things that have developed, really, when you think of positioning patients in the prone position and the workarounds. So One of the other things I thought about then as well that nurses might be interested in, so you did mention that patients could be prone for long periods of time, perhaps up to maybe 16 hours in some cases. Um, how often is a patient's head repositioned and how is that undertaken and achieved? And how important is that to do?
So the repositioning there is extremely important. I think leaving people in one prolonged position, as we said, for up to 16 hours is quite a significant risk of pressure injury. The recommendations are usually that the head would be turned every 2 to 4 hours. And if you are utilizing the swimmer's position, that will again be a team who can help to lift the patient a little, turn the head, and then maneuver the arms safely, but really paying care and attention to those shoulder joints, which are very unprotected. One of the risks when you have these flaccid, paralyzed limbs is it's very easy to overstretch, overpull, over rotate. So it is about having enough people around, probably at least 3 for that change in position. But if the stability allows it, they should be turned every 2 to 4 hours, really.
Mm. And I wonder, David, in your role as physiotherapist, have you been involved in any sort of follow-up of patients after ICU, patients who've been in a prone position? We've come across any of these injuries, or indeed, would patients have been aware? I know they may be ventilated, or they will be ventilated, but obviously they may be well sedated. But would patients ever have talked about being aware of being in the prone position?
So we've not actually had any patients who have come back aware of being in prone position, but we've certainly seen quite a high instance of upper limb injury.
Mm-hmm.
I think there's a combination of factors which might have come into this. One, the sheer number of times and repeated need for proning. I mean, some of our patients were prone for almost 7 to 10 days straight to manage that oxygenation. I think the acuity of illness meant that it wasn't always possible to reposition them when they were in prone due to desaturation or just cardiovascular instability. And I think the sheer volume of patients that we saw at the time as an intensive care, we peaked at over 100 ventilated patients at one time. So the skill mix changed very quickly and it became very difficult to manage people. But certainly, I think with robust check-in procedures in place, I think with good communication between teams, I think regular turning as and when is appropriate, I think a lot of these things can be avoided. One of the things we're seeing quite interestingly of late is actually a move towards awake proning. And some of our
Mm.
patients who come down on kind of high flow oxygenation but don't need ventilating as such, where they're actually lying on their front, and that is also utilizing the benefits of improving gas exchange before they go onto a ventilator. I think that's something we're starting to see more and more in practice as well.
Yeah, that's really interesting, isn't it, to see the benefits of that.
Yeah.
And my final question is, what happens if a patient has a cardiac arrest when they're in a prone position? How's that managed?
Yeah, I think this is one of those things from my perspective as well that you don't really think of. And then when you do, you suddenly have that, oh God, what would we do kind of moment.
Hmm.
So I think there are generally unit policies for this. I think the initial instinct you would imagine would be to flip people over, but that's not what is recommended. I think turning somebody that rapidly would come with quite significant risk of displacing the ET tube, possibly displacing lines, causing injury to staff members. CPR can be started in a prone position. There's no specific recommendation, but generally it says about starting compressions around mid-thoracic level. You can also carry out defibrillation in a prone position as well, and there's been some success there. But I think the main message really is if the patient's getting to a point where they may arrest or they do arrest, it's about you've got a very highly trained team around you, an incredibly skilled intensive care team also working on the unit. Just ask for help. And as soon as you do, that team will come in, take over and manage that situation in a very professional and efficient way.
That's great, David. Thank you very much. Again, a very informative, excellent talk. Thank you.
Thank you.